So, good morning, friends. Today's guest speaker is Professor Aristoteles from Germany. This webinar is brought to you by Mumbai Hematology Group. It is supported by Dr. Reddy's and it's managed by Mice Ideas. I'm thankful to Dr. Reddy's, Rajesh Kalpesh and their team from Mice Ideas, Executive Committee of Mumbai Hematology Group, our guest speaker, Professor Dr. Aristoteles Giagonidis from Germany, our chief guest, Dr. Biju George, discussants of today's webinar, and all of you for sparing your Sunday morning. Just to introduce the next weekend activities to you, Saturday evening, 7 p.m. is Dr. Amir Zaidan from Connecticut, US, telling us about management of older patients with acute myelodysplastic leukemia, the rapidly changing landscape. And the next day in the morning, Sunday, from Spain, Dr. Maria Victoria Metius is going to tell us about how to cure multiple myeloma. Today's discussants include Dr. Shyam Agrawal from Bhopal, Dr. Bhavin Shah from Ahmedabad, Dr. Neeraj Siddharthan from Kochi, Dr. Pranta Chakrabarti from Kolkata, Dr. Sonali Sadarwate from Australia, Dr. Prashant Bhatt from Mangaluru, Dr. Ramaswamy from Kochi, Dr. Anup from Bangalore, Dr. Meet Kumar from Gurugram, and Dr. Anil Airam Singh from Imphal. It's my pleasure to introduce our guest speaker, Professor Aristoteles. He is Professor of Internal Medicine and Chief Physician for Oncology Hematology at the Marian Hospital in Düsseldorf, Germany. After earning his medical degree in 1992 from Eberhard Karl University in Tübingen, Germany, he was house officer at the Wijdebush General Hospital in Haverfordwest, Wales, and at the William Harvey Hospital in Ashford, Kent, UK. He then served as the resident physician at the Hematology Oncology Department of Heinrich Heine University of Düsseldorf, where he became board certified in 1999. Due to his special expertise in hematological cytology, he later became central reviewer of the German MDS study group. His research efforts have focused on myelodysplastic syndrome and ITP. His clinical practice focuses on hematological malignancies, including acute and chronic leukemias, MDS, MPNs, lymphomas, and plasmacytomas. Recent years, he has been involved in several phase 1 to 3 studies of several groundbreaking therapeutic approaches in MDS, ITP, and iron overload, among others. A frequently invited speaker, he has delivered numerous lectures at local, national, and international conferences and symposia. A reviewer for several scientific journals, he has authored and co-authored various book chapters and numerous articles published in peer-reviewed journals such as NEJM, Blood, Leukemia, Proceedings of the National Academy of Sciences of the USA, Annals of Hematology, and Hematology. He is a member of the advisory board of several international drug manufacturers, including Novartis and Celgene. Above all, he was our guest speaker in Mumbai just a couple of years ago. As usual, the Sunday quiz for you. And as you know, that after the quiz has been spelled out to you, you have to email the answer on the email ID given to you, and the first correct answer will get the prize. So we have a 74-year-old man with multiple myeloma, IgG kappa monoclonal gammopathy, and advanced bone disease. He also had chronic abdominal cramping and a duodenal ulcer. Bone marrow examination showed 38% plasma cells and a multifocal, dense, paratrabecular and perivascular clustering of abnormal cells, which accounted for 16% of these cells in the aspirate. And this is the aspirate showing you a large population of plasma cells, and those cells which we are discussing today, pointed out by the arrow, two of these cells are seen to you in this field. Have a good look at it before I proceed further. The question is related to these two cells. Okay. The flow cytometry showed that these cells have expression of CD2, CD25, and CD30. Serum tryptase level was high, cutoff being 20. Patient had 161 nanogram per ml. NGS revealed KIT D816V mutation. The question to you is, what is the exact complete diagnosis beyond multiple myeloma? You have to email your answer to mbagarwal1@gmail.com. mbagarwal1@gmail.com. Now it's time to introduce our chief guest. It's my proud privilege to introduce my friend, Dr. Biju George, Professor, Department of Clinical Hematology at CMC Vellore. He did his DM in clinical hematology in 2002. Subsequently, he was involved in setting up protocols for diagnosis and management of various infections following chemotherapy and stem cell transplants. His areas of interest include marrow failure disorders, both congenital and acquired. He has also developed specialized protocol for Fanconi's anemia. He has a DBT-funded study to look at biology of aplastic anemia, especially telomere biology. He spent 3 years in the hematology department of Westmed Adults Hospital in Sydney, Australia, where he received valuable experience in alternate donor transplants. He subsequently set up this facility at the CMC Vellore, and the group has now completed over 300 haplo-identical transplants. His present research concentrates on cellular therapy for management of refractory hematological malignancies. He is a reviewer of many renowned journals. To name a few: Aplastic Anemia, British Journal of Hematology, Bone Marrow Transplantation, Hematologica, amongst others. He is Vice Chair, Asia, Africa, Australia Advisory Committee for the CIBMTR. He is also chair of the Working Committee for Congenital Bone Marrow Failure Disorders in APBMT. He is a member of many important bodies, including ASBMT, APBMT, ASH, ISCT, and Indian Society of Hematology and Transfusion Medicine. It's my privilege to request him to inaugurate this webinar and give us some words of wisdom. Over to Dr. Biju George.
Thank you very much, sir. I'd like to start by thanking Professor Agarwal for inviting me to this webinar on MDS. Now, I'm sure all of us would agree that advances in medical knowledge is moving in leaps and bounds. And sometimes it's very difficult for us, especially in our busy work schedule, to remain at the forefront of acquiring knowledge. But as one of my former medical teachers actually told me, it's never too late to learn something new. And therefore, in our life as medical professionals, I think we need to strive to learn more each day, because the day we decide to stop acquiring knowledge, I think we move into a free fall. This acquiring knowledge is probably not just important professionally for each one of us, but I think it's also very important because it's needed to impart the best that we can to our patients. This is much more so in a country like India, where we are constantly struggling to find a fine balance between giving the best of our medical treatment to our patients and the constant financial hardships that these patients need to face towards their treatment. To make our knowledge relevant, we need to learn the art of practicing what is feasible in our country and understanding what stays in the realm of medical advancement. And this is probably very true of a disease like MDS, where unlike the West, where the median age of diagnosis is 65 years, we are looking at a median age of diagnosis of about 45 to 50 in our age group. Therefore, as doctors interested in treating MDS in India, our perspective is always slightly different. We need to look at a more curative approach for at least for the younger patients and a supportive care approach for our older patients. Therefore, we need to be innovative in the way we approach drugs, treatment options, and the algorithms that we use to manage MDS so that our knowledge remains relevant for our patients. It has often been quoted, knowledge shared is knowledge squared. These webinars that are held, I think, are very relevant in helping us improve in our understanding of the disease, and I think very importantly, in helping us keep up to date with these advancements despite all the travel restrictions that have been imposed on us because of the pandemic. With these words, I would like to inaugurate this webinar on MDS and wish you all a very educative experience over the next 2 hours. Thank you very much for inviting me, sir.
Thank you so much, Dr. Biju, for those kind words and inaugurating this webinar. We are really honored. Now we go into the scientific part of this webinar. It's my pleasure to invite Professor Aristoteles, whom I have just introduced. So over to Professor Aristoteles.
Thank you very much, Professor Agarwal. It's a great pleasure to seeing you again and being at least virtually back to India. I would have preferred, obviously, to being there in person. I would like to thank Dr. Biju also for giving those real words of wisdom, and would like to start then with a talk about myelodysplastic syndromes. Now, as you know, I'm from Greek ancestry, and it's very difficult for Greeks we are not very communicative in the morning. So when I heard that it would be 7 o'clock in the morning when I have to give this talk, I thought back and forth how to work around that. And I actually took a flight to Greece, and I'm at my mother's house now. So it's actually 1 hour later, it's 8 o'clock here. So I'm much fresher and it's much easier for me to give the presentation. Okay. So I'm going to share my presentation with you. Here we are. Can you see it?
Yes.
Wonderful. So I'm going to talk about the management updates of myelodysplastic.
Sir, put it on a slideshow mode.
Yes. I'm going to. There we are.
Yeah.
Going to talk on management updates on myelodysplastic syndromes, and all, as you all know. One more thing. I've started a couple of months ago putting up on Twitter at the hashtag morning cytology rounds interesting cytology stories that we have come up. I'm giving a morning lecture every day at the hospital from Monday to Friday. We are having about 15 to 30 minutes of review of cytological bone marrow slides. I love the one that you have shown with the wonderful plasma cells, and the others, which I'm not going to comment about. But so every morning we are setting up a little review, and then the most interesting of those are being put up on Twitter. So if you're interested at the morning cytology rounds, you can follow that. So management updates on myelodysplastic syndromes. As you all know, mutations in myelodysplastic syndromes are very broad, and we have DNA methylation, RNA splicing mutations, chromatin modification mutations, and others. And these lead to the problem that we have the hematopoietic stem cell developing into an MDS stem cell. And then we have, unfortunately, a large number of subclones that can develop, and those subclones then eventually will transform into acute myeloid leukemia stage. And the problem really is that we have few gain-of-function mutations in myelodysplastic syndromes, which are less amenable to targeted inhibition, which has slowed down the optimal treatment of myelodysplastic syndromes in the past, but we are doing steps forward, and this is what I'm going to talk about over the next couple of minutes. I would also like to remind you that in the pathophysiology of myelodysplastic syndromes, myeloid-derived suppressor cells play an important role, and the damage-associated molecular patterns, DAMPs, and the pathogen-associated molecular patterns, PAMPS, are of especial importance. Here on the left side, you see the myeloid-derived suppressor cell, a CD33 positive lineage negative cell, which on the one hand secretes TGF-beta superfamily members, and I'm going to come back on that in a minute, and also so-called alarmins like S100, A8, A9, and so on, which can either help self-renew the cell because they bind to CD33 on the cell, which is a positive loop, or bind through toll-like receptors or CD33 on other cells in the bone marrow, and they're leading to a signal transduction, which will start an inflammasome production, and the inflammasome production then through caspases and other molecular patterns leads to pyroptosis and apoptosis of those cells. Erythropoiesis itself is being complex and tightly regulated, involving, on the one hand, the erythroid proliferation and the erythroid maturation. And as we have learned, erythropoietin and its receptor is most prevalent in the colony-forming unit erythroid, proerythroblast, and basophilic erythroblasts, while the maturation itself of erythroid cells, both the proliferation and erythroid maturation, seems to be regulated by GATA2 and GATA1, and the switch from GATA2 to GATA1, which then leads to differentiation of the progenitors and expression of the more mature erythroid cells. Finally, the TGF-beta superfamily that I've just alluded to is very important, and in the erythroid maturation part of the red lineage leads actually to suppression by suppressing SMAD2 and 3 signaling. Therefore, it's of a certain importance to target TGF-beta superfamily members to improve erythroid maturation. Iron uptake starts from the proerythroblast and later, and the tight regulation of erythropoiesis is crucial to ensure steady-state erythropoiesis and maintenance of sufficient hemoglobin concentrations. Now, SF3B1 mutation is one of those that I have shown previously. lysosome mutation, which is of particular importance because it is prognostically beneficial in myelodysplastic syndromes, and patients with an MDS count of less, with a blast count of less than 5% in the bone marrow and an SF3B1 mutation seem to have very similar overall disease progression behavior, regardless of the fact whether they have unilineage dysplasia or multilineage dysplasia. The SF3B1 mutation comes with approximately 30% incidence in unselected MDS patients and in 20% of patients with an MDS-MPN overlap syndromes. It is present in 70% of ring sideroblastic myelodysplastic syndromes, but also in 10% of MDS with ring sideroblasts lower than 15% of erythroid lineage. So high concordance and correlation between SF3B1 mutation and ring sideroblastic phenotype, and the mutant allele burden strongly correlates with the percentage of ring sideroblasts in the bone marrow. Luspatercept has been expressly developed to target TGF-beta superfamily members and act as a ligand trap to TGF-beta superfamily members that suppresses SMAD2/3 activation. It increased hemoglobin in healthy volunteers and also in murine models of myelodysplastic syndromes. Its murine analog corrected ineffective erythropoiesis, reduced erythroid hyperplasia, and increased hemoglobin. So the Medalist trial, which has been presented a couple of years ago, and of which I'm going to give some updates, was a trial which randomized 2-to-1 luspatercept and placebo in myelodysplastic syndromes with ring sideroblastic disease with less than 5% blast in the bone marrow, no del(5q) MDS allowed, and with an IPSS revised score of very low, low, or intermediate. And those patients should have had prior ESA response or should have been refractory or intolerant to erythropoietin, or should have an erythropoietin level of above 200 units per liter, plus being red blood cell transfusion dependent with an average RBC transfusion burden of more than 2 units every 8 weeks. No prior treatment with disease-modifying agents was allowed, and disease and response assessment was done every 6 months, and subjects were followed longer, with a primary endpoint of red blood cell transfusion independence of more than 8 weeks, but a key secondary endpoint of red blood cell transfusion independence of above 12 weeks, and additional secondary endpoints like hematological improvement erythroid, with a reduction in red blood cell transfusion burden of more than 4 units every 8 weeks for patients who had high transfusion burden, or for patients with lower transfusion burden, a hemoglobin increase of more than 1.5 grams every per deciliter over 8 weeks, as well as duration of response and hemoglobin change. And what has become apparent is that luspatercept in weeks 1 to 24, so in the first 6 months of treatment, actually led to a 38% red blood cell transfusion independence compared to placebo with 13%. Placebo patients who have become transfusion independent did not, throughout the board, achieve a hematological improvement erythroid in the sense of an increase of more than 1.5 grams per deciliter of hemoglobin. The p-value was highly statistically significant, and as you can see here, the transfusion independence rates for more than 12 weeks was also pronounced, with 28% in the luspatercept limb of the study and 33% if you looked at weeks 1 to 48, with both p-values being highly statistically significant as shown here. Now, luspatercept is somewhat a peculiar drug because it's not necessarily in the first 24 weeks that you achieve a transfusion independence, but it may happen that you achieve transfusion independence later, or that you achieve transfusion independence for more than 8 weeks at different points in time throughout the study. And as the study went on for 3 years, you can imagine that patients who have had different spells of transfusion independence for more than 8 weeks have had an additional benefit. And here you see a presentation by Pierre Fenot from France, who showed that red blood cell transfusion independence for over 8 weeks achieved at any time during the treatment period happened in about 50% of patients on the luspatercept limb of the trial, compared to 16% in the placebo arm. And if you look at the cumulative duration of RBC transfusion independence of greater 8 weeks in all responders, with a data cutoff of July 2019, this goes to show that the luspatercept patients achieved a cumulative duration of red blood cell transfusion independence of greater 8 weeks in 80 weeks versus 21 weeks with placebo, which is an important discriminator of those two therapy limbs. Also, the achievement of red blood cell transfusion independence, hematological improvement, erythroid, is somewhat dependent on the dosage given. And as you remember, the luspatercept dose was an increase in dose from 1 milligram per kilogram body weight over 1.33 milligram per kilogram body weight to 175 milligram per kilogram body weight, depending on response of the patients. And as you can see here, in the overall achievement of red blood cell transfusion independence, a higher dose usually led to a higher improvement in red blood cell transfusion independence. And this was also importantly different according to the baseline transfusion burden of those patients. On the other hand, the treatment emergent adverse events were not higher with a higher dose. As you can see here, the impression is that if you get a treatment emergent adverse event, it will happen irrespective of the dosage. Most probably it will happen at the 1 milligram per kilogram body weight dose, but it's not going to increase if you increase the dosage of the drug. Now, this is what usually happens with the patients. You have you administer the drug. You have a response of hemoglobin, and then the hemoglobin tends to increase and remain increased over a longer period of time. And interestingly enough, we have had a couple of patients who actually interrupted treatment with luspatercept and remain transfusion dependent with a hemoglobin level above 1.5 to 2.5 or 3 grams per deciliter over a long period of time. And I'm meaning several months, even years in this respect. Excuse me, I'm going to charge my laptop for a second. So there we are. So the safety summary of the medalist trials shows that treatment emergent adverse events happen. However, if you look down here, the treatment emergent adverse events causing discontinuation, they are pretty low and they are on placebo level indeed. So the swimmer's plot, in my opinion, gives us a nice view of what happens with luspatercept. You see on the left side of the panel, of each panel, you see the number of transfusions that have been given to the patients. And then what you can see is that some patients actually with administration of luspatercept become completely transfusion independent. Others will have a spell of transfusion independent will need another transfusion and then become transfusion independent again. And this may happen at different time points. And indeed, some others will have larger and smaller durations of transfusion independence throughout their treatment with luspatercept, while some patients will have very low improvement with luspatercept, as shown here. But I think it's important to say that 70% of the patients have more than equal or more than 2 separate response periods, and 20% of the patients have had 4 separate response periods. So this is important to bear in mind when we are talking about the cumulative incidence of transfusion independence of the patients. Now, an alternative to luspatercept will probably become available in the future, which is called imetelstat. And imetelstat has been presented by Uwe Platzbecker at the American Society of Hematology meeting in heavily transfused patients with non-del(5q) lower risk myelodysplastic syndromes who were relapsed or refractory to erythropoiesis stimulating agents. And as you know, the telomeres are highly important. And if we did not have telomerase, then after 40 or 50 cycles of mitosis in our cells, the telomeres would have been used, and we would then use a chromosomal material, replicative chromosomal material, and the cells would undergo apoptosis. Now, imetelstat actually inhibits the telomerase activity, which targets especially malignant progenitor cells with higher cycling, and therefore has the potential to be a disease-modifying agent. There's a phase 2-3 study called iMerge that is partially complete, and these 38 patients were patients this talk was going to address. And there's a currently enrolling phase 3 double-blind placebo-controlled trial with imetelstat comparing to placebo. Meaningful and durable transfusion independence has been achieved with imetelstat treatment. As you can see, the 8-week transfusion independence happened in 42% of patients, with a duration of transfusion independence of 88 weeks in median, which is actually very encouraging. Hemoglobin rise of more than 3 grams per deciliter happened in 32%. So it seems that the drug has a robust responses, and also a third of patients has had 24-week transfusion independence rates, and a young 1-year transfusion independence rate happened in about 30% of patients. Again, a swimmer's plot shows you in green transfusion independence for equal or greater of 8 weeks, shows you a similar pattern to what we have seen with luspatercept, with again 29% of patients remaining transfusion-free for at least 1 year. Another important update, in my opinion, is how we should act with hematopoietic stem cell transplantation, allogeneic stem cell transplantation. And now I switch to the more aggressive forms of myelodysplastic syndromes. And here this was a comparison of using hypomethylating agents or best supportive care, or comparing this to reduced intensity allogeneic stem cell transplantation in patients aged 50 to 75 years with advanced myelodysplastic syndromes. And this comes from the American Blood and Marrow Transplant Clinical Trials Network. And what you can see in the as-treated analysis is that there is an absolute improvement of 31% for patients who had undergone allogeneic stem cell transplantation, which also translates to an absolute improvement in leukemia-free survival of this patient population. And interestingly enough, if we look at the quality of life, the different scores from physical component to mental component, the total score, utility score between donors and no donors seem to be at least not worse for patients with who have undergone allogeneic stem cell transplantation. Instead, with the stars, you can also see patients who actually have an improvement, statistically significant improvement. But at least it does seem that patients undergoing reduced intensity allogeneic stem cell transplantation do not seem to have a reduction in quality of life over the long-term course of the treatment. Another important presentation was given by Michael Zacharias from Cleveland Clinic, who has now moved to Miami, and he presented on the efficacy and safety of pevonedistat plus azacitidine versus azacitidine alone in higher risk myelodysplastic syndrome. And this is an important approach because pevonedistat is an inhibitor of nedylation. Nedylation means that you get ubiquitination of select proteins upstream of the proteasome, and inhibition of nedylation blocks the ubiquitination of this upstream proteasomic ubiquitination, and disrupts therefore the cell cycle, the progression and cell survival, leading to cell death in cancers. And the study was a phase 2 randomized open label study, and Michael presented on the higher risk MDS component, the MDS patients of this study. Pevonedistat and azacitidine was randomized 1:1 to azacitidine. Pevonedistat was given IV on days 1, 3, and 5, while azacitidine was used in the now, I think, well-known way of days 1 to 5 and days 8 and 9, leaving out the weekend. And the analyses in patients with higher risk MDS are being presented here, reminding you that the results in the ITT population showed for the entire patient cohort of MDS, CMML, and AML patients a median event-free survival of 21 months with pevonedistat and azacitidine versus 16.6, and 22 months versus 19 months median overall survival. Now, for the MDS category, for the MDS component of this study, patients with higher risk MDS, according to IPSS revised, were included. And you see that event-free survival and overall survival both favored pevonedistat and azacitidine, albeit the p-value only for event-free survival became statistically significant, not for overall survival. However, if you look at the CR rate, it was nearly doubled with pevonedistat added to azacitidine, and the median duration of response was almost tripled with pevonedistat and azacitidine compared to azacitidine, as shown on the right side of the panel. The rate and duration of red blood cell and platelet transfusion independence was also increased, as shown here, with 70% RBC and platelet transfusion independence with the combination, compared to azacitidine alone of 47%. And the median duration of transfusion independence is 23% for the combination versus 11% with azacitidine alone. Now, combinations are I think, the way to go if we want to have the backbone of azacitidine. And therefore, it was interesting to see oral presentations 657 from Australia, from Boston, Massachusetts, and Australia, with Andrew Brunner presenting on sabatolimab in combination with hypomethylating agents in patients with high risk myelodysplastic syndromes and acute myeloid leukemia. Now, TIM3 is a target both on leukemic cells and on immune cells. And interesting enough, sabatolimab binds to TIM3 on immune cells, and by that enhances anti-leukemia immune activation and phagocytic uptake, facilitating cell-mediated killing of leukemic stem cells and blasts. On the other hand, it also targets TIM3 on blasts, on leukemic cells, through high affinity binding of TIM3, and blocks TIM3 on leukemic stem cells, which inhibits self-renewal on those cells. It's interesting as a concept because TIM3 is actually present only on leukemic stem cells and blast cells and on those macrophages that actually attack those leukemic stem cells and blasts, and therefore enhances their phagocytic activity and facilitates the cell-mediated killing. Now, what did they do? They had very high risk or high risk myelodysplastic syndromes, newly diagnosed acute myeloid leukemia and chronic myelomonocytic leukemia, and they treated the patients with hypomethylating agents, decitabine or azacitidine, and added sabatolimab from day 8 to day 22 in different dose levels, as you can see here, every 2 weeks, 240 milligrams, 400 or 800, and then again at day 22, 240 or 400 milligrams. And primary endpoints were the maximum tolerated dose, and the preliminary efficacy was secondary endpoint with response rates and duration of responses. And it was interesting to see that the median time to response was actually lower than with azacitidine alone. 84% of patients had an estimated percentage of patients still in response after 6 months was 84%, and you have an estimated 12 months progression-free survival rate of 52%. And as you can see, bridge to transplant was actually feasible in a couple of patients, in 9 patients overall. And what you can see here is that response rates actually happen both as complete responses and as marrow responses. So I think sabatolimab is also an interesting drug to follow in the near future. Now, looking at the subgroup of very high-risk myelodysplastic syndromes, you see encouraging response rates with a CR rate of 31% and the marrow CR rate with hematological improvement of 18%, summing up to about 50% of responses, CR and marrow CR with hematological improvement. And you can see that several patients over the course of disease actually achieved a CR or marrow CR and continued treatment. Others have undergone allogeneic stem cell transplantation. And then obviously the MD Anderson study group presented on what we already knew from acute myeloid leukemia to be kind of a game changer, is the combination with azacitidine and venetoclax in patients with myelodysplastic syndromes. And you see here on the left side, the high-risk myelodysplastic blast cells being dependent on certain cytokines which are being inhibited by the drugs. Will lead to synergism, apoptosis induction, and therefore apoptosis of these cells. And it was a dose escalation study Venetoclax was added at 400 milligrams at the beginning, day 1 to 28 to azacitidine, and then dose escalation phase was amended to 14 days of venetoclax, 100, 200, and 400. And finally, they went on with the safety expansion cohort with Aza and venetoclax 400 milligrams for 14 days and followed up with safety expansion second cohort with key inclusion criteria of no prior treatment of MDS, IPSS of higher than 1.5, equal or higher of 1.5, and a bone marrow blast count of less than 20%. And these are the baseline characteristics with a majority of male patients, with patients with a high blast count as shown on the left side, 30%, 5 to 10%, and 63%, 10 to 20%, and intermediate and a poor risk cytogenetics in about 60% of patients. If you look at the adverse events, the one thing that is concerning is neutropenia and febrile neutropenia, because as you can see here, neutropenia and febrile neutropenia, grade 3 and 4 does happen in a large amount of patients. So we need to learn how to tackle that, especially in a patient population that suffers from cytopenias very often to begin with. Now, any severe adverse events here shown again, neutropenia, febrile neutropenia, pneumonia, diverticulitis. So this is something we have to look at. But if you look at the response rates and the transfusion independence, this is also very encouraging with CRs and marrow CRs on the left side, adding up to about 80% of patients, no PRs seen in this study, and red blood cell and platelet transfusion independence rate of 65%, 67 red blood cell, 77% platelet transfusion independence, which is actually pretty impressive. 47% of patients achieved overall response rate by cycle 2, and 78% achieved overall response rate by cycle 3. And here you see the overall survival by response with patients in green and in orange with marrow CR and hematological improvement doing very well indeed. And I think we can conclude then venetoclax and Aza demonstrates efficacy, including response durability and an acceptable safety profile for patients with high-risk myelodysplastic syndromes. The dose to go is 400 milligrams day 1 to 14, but we need to watch neutropenia and infections. And further studies are ongoing in this indication with venetoclax and azacitidine. Finally, I would like to touch upon the anti-CD47 antibody magrolimab combined with azacitidine in acute myeloid leukemia. You know that CD47 is a don't eat me signal, which when blocked leads to phagocytosis. You see on the left side the control panel, no phagocytosis with a control myeloid monoclonal antibody. But if you look at the red macrophages below in anti-CD47 monoclonal antibody, you see that phagocytosis is actually strongly enhanced. And you see that the green cancer cells are being phagocytosed by the red macrophages. So the magrolimab study was a combo study with azacitidine to evaluate the safety, and then there was an expansion phase. Again, primary objectives of safety and efficacy, secondary objectives of pharmacokinetics and additional measures of efficacy, and then some exploratory objectives also. You see that median age range was 71 years, as we would expect for myelodysplastic syndromes. A lot of mutations, and especially 73% of patients with TP53 mutations, which is very difficult to tackle, as we all know. 70% of patients had poor risk cytogenetics, and 53% of patients had underlying myelodysplasia, myelodysplastic related changes in their bone marrow. And there was no maximum tolerated dose reached with magrolimab and azacitidine, and no significant increases in cytopenias, infections, or immune-related adverse events. The 30-day all-cause mortality was 5%, which is very impressive in my opinion, with a 60-day mortality of 8%. And 5% of patients had some kind of adverse event leading to magrolimab dose reduction, which in my opinion is low. Treatment discontinuation happened in about 5% of patients. And if you look at this waterfall plot, you see that the blast reduction is actually relatively impressive in those patients. And if you look at the left part of the panel, 63% of patients with acute myeloid leukemia had an overall response rate, 70% of those with TP53 mutations. Suffice it to say that, magrolimab with azacitidine seems to be an important addition to the armamentarium of AML and probably high-risk myelodysplastic syndromes. And it's going to be interesting to see how the combinations with magrolimab, with TIM3 inhibitors, sabatolimab, with venetoclax, etc., are going to add up to improve on the deep responses that we can see with either of those drugs. Here you see the swimmer's plot of magrolimab and azacitidine, durable responses achieved, deep responses achieved, RBC transfusion independence achieved in 70%, complete cytogenetic responses achieved in 50%. This looks pretty encouraging in my opinion. And I'm very much looking forward to seeing how we are going to even improve on those results. I mean, look at the TP53 wild type and mutant results. Actually looks encouraging even for TP53 mutant, because this will give us the possibility to transfer several of those patients to a transplant setting, in my opinion. So as a conclusion, magrolimab is the first-in-class antibody targeting the macrophage checkpoint CD47, is well tolerated. Regardless of TP3 mutation status, it shows encouraging efficacy, and the preliminary median overall survival in TP53 wild type and mutant is promising in this treatment setting in terms of historical treatment. And we are really looking forward to additional development of magrolimab and the other drugs in higher risk myelodysplastic syndromes. And with this, I would like to stop. I invite you to discuss this talk and look forward to your questions.
Thank you so much, Dr. Aristoteles. That was a wonderful update, lot of learning, and I'm sure that everybody who has tuned in must have benefited in a big way. We almost 400 plus audience who have been listening from all around the world, half of them from this country and rest from everywhere. Just before we take up our discussions for asking you the questions, I will just release the answer of the quiz and then come back to the questions. I'll just share my screen. Yeah, can you see my screen?
Yes.
Okay, so the quiz was that we had an elderly man with multiple myeloma who had a multifocal dense clustering of abnormal cells of 16% in the paratrabecular perivascular region. And then you were shown this aspirate film in which besides plasma cells, there were these two cells which were marked, the spindle-shaped cells which are densely granulated with long cytoplasmic projections. I must say that enthusiasm was tremendous. We got over 80 responses, and 11 of them were close. So we'll be talking about those 11 people. I think those 11 picked up at least what these cells were. As you saw that the flow cytometry was quite characteristic together with tryptase elevation and this mutation. So they picked up that these were mast cells. Flow cytometry, tryptase, and the mutation. The problem happened was that we had asked the question, what is the exact diagnosis? So if you look at systemic mastocytosis, which was answered by 12, systemic mastocytosis is a clonal neoplastic proliferation of morphologically immunophenotypically abnormal mast cells. The sine qua non for mastocytosis is the presence of this multifocal cluster of abnormal mast cells which have variable appearance ranging from round to fusiform cells. And you saw those two fusiform cells with long polar cytoplasmic processes, often cytoplasmic hypogranularity and monocytoid nuclei, by which when the diagnosis can become a bit difficult on morphology. And what you saw in those, and this is of course another case showing you another that kind of mast cell which is spindle shaped with long polar projections. The 2016 WHO classification of systemic mastocytosis gives you various subtypes. And when we asked for a complete answer, we expected you to go to the subtype. And that's where the problem happened a little bit, that out of 12 people, 3 got the exact subtype. So you have these types: systemic mastocytosis, indolent, smoldering, aggressive. Then systemic mastocytosis with the AHN, that is associated hematological neoplasm. Then aggressive systemic mastocytosis, mast cell leukemia, and the mast cell sarcoma. And we wanted you to go beyond systemic mastocytosis to pick up one of these 5. So the answer was SM-AHN. Now SM-AHN, the associated hematopoietic neoplasms, is the second commonest SM subgroup, accounting for about 40% of the systemic mastocytosis in the Mayo series. 85% of the associated hematological disorder is a myeloid neoplasm, myeloproliferative neoplasms, CMML, and MDS, the 3 being the commonest. Among SM-MPN, this group, some may have prominent eosinophilia and harbor the FIP1L1 PDGFRA fusion. The other hematological disorders which may be associated are myeloma, lymphoma, CLL, amyloidosis, and even some other rare conditions. And our patient fell here, myeloma with systemic mastocytosis, AHN. So the answer was systemic mastocytosis with AHN. I'll tell you these 12 names. So the 9 names that came close to the diagnosis but missed the part associated hematological neoplasm were these: Dr. Giri Punja, Dr. Usha Agarwal, Dr. Sonali Sadavarte, Dr. Vineet John, Dr. Gunjan Prasad, Dr. Ledendri Jivani, Dr. Javed Tamboli, Dr. Aishwarya Raj, and Dr. Paresh Dave. So you all came very close, but not complete. So excellent, very good. Out of 80, you 9 stand out. And then 2 of you got exactly the correct answer, but you were not the fastest. So congratulations to you, Dr. Tanuja Desanaike from Sri Lanka and Dr. Sumit Mirk. Your answer was exact. And then we have the winner who gave the complete and the correct answer and also was the fastest finger first. And the person is Dr. Akanksha Garg. So congratulations, Dr. Akanksha Garg. Dr. Akanksha Garg is Assistant Professor, Department of Medical Oncology in the prestigious Gujarat Cancer Research Institute, Ahmedabad, and she has been our faculty and discussant at a large number of meetings. So congratulations to you. Well, thank you so much. And now I stop sharing my screen and we go to the questions. Let's begin with Dr. Shyam Agarwal. Dr. Shyam, your question, and after that will be Dr. Bhavin Shah. You keep your question ready.
Yeah. Good morning, sir, Dr. Aristotelis. And really, it was an excellent presentation, a lot of new insight into the management of MDS. My question is like, do you decide, am I audible, sir?
Yes.
So my question is, like in myeloma, as we decide with patient with high risk MDS goes with transplant eligible, non-transplant eligible, or you have different pedigree for that? And if it is non-transplant eligible, then what the pedigree you start with the new HMAs or HMAs with targeted therapies like, as you said, magrolimab, or the non-targeted venetoclax, etc. So how you go ahead with the high risk MDS non-transplant eligible?
Yes. So first of all, thank you for the question. You are absolutely right. So what we do is we categorize our patients really into transplant eligible and non-transplant eligible, which most often is a function of finding a suitable donor in the international databases. And also the comorbidities, really. We use a comorbidity score that allows us to understand whether this patient is going to have a sensible probability of survival and of doing well. The majority of those patients over the age of 70 will not make it to the transplant setting, I would say, because of comorbidities, not so much because of donor availability. And then what we usually do is we try and put them on clinical trials with at the moment sabatolimab, at the moment also magrolimab, and for the lower risk MDS patients for imetelstat, etc. However, I think it has now become standard of care to use venetoclax in this country with higher risk myelodysplastic syndromes in combination with azacitidine. So what the insurance companies have accepted is the high rate of CR and marrow CR that has become apparent from the AML trials, and they do allow us to use it in higher risk MDS also.
Okay.
Thank you, Shyam. Dr. Bhavi.
Yeah. Good evening, sir. It was an excellent presentation. So my question is, most of our patients with high-risk MDS received HMA, and the problem starts when they are transplant ineligible and they failed on HMA. So what treatment option do you have for this group of patients?
Yeah. This is the worst patient population, obviously. So you have a transplant ineligible patient who has failed HMA. And what we are doing at this moment is that we are trying to reinduce those patients with HMA and venetoclax. However, I would like to point out that some of those patients are severely cytopenic and may actually undergo additional cytopenia and long-term cytopenia. I have one patient now at the moment on the ward who is 60 plus days completely ablated of any neutrophils. We have 1% neutrophils out of the 600 or 800 white blood cells that we see in this patient. After failing multiple treatments for advanced myelodysplastic syndromes, and therefore, although she has received a marrow CR, we did a bone marrow, and there's no malignant cell left in the bone marrow. I do agree that this is a difficult still problem in the daily clinical care, because those patients may lose the malignant but also the benign stem cells once treated and retreated and then retreated, and then at the end of the day you add the BCL2 inhibitor.
So
but
can
still,
I ask you?
I think, but still, I think it's still a valuable option. Just I think we should to stick to the maximum 14 days of venetoclax in those patients. So I really treat them with azacitidine, give them the venetoclax, and then immediately after 14 days I stop, because otherwise, the risk of long-term neutropenia is very high.
So do you reduce the dose of venetoclax if the patient have grade 4 neutropenia in a previous cycle? Or you continue with the 400 milligrams?
Yes, we go to 200 milligrams if they have had a previous neutropenia. But the problem is the first cycle. In the first cycle, you start with 400, and you may actually end up with severe neutropenia from those 400 milligrams, and that can be tricky.
And many patients have an IDH mutation in NGS. So IDH2 inhibitors, or does they have any role in such a group of patients?
Absolutely, absolutely. And there is a trial with enacidimab running in our country at this moment. So we are trying to add IDH2, but also IDH1 inhibitors if you have a IDH1 mutation. So I think that's very valuable. Yes, absolutely. So at the end of the day, any targeted mutation should be targeted. If you can't target a mutation, then you need to take this broad spectrum of treatment, with BCL2 inhibition, which then again can be tricky, but I think is worth a trial.
Thank you. Thank you very much.
Thank you. Dr. Neeraj. Unmute yourself. Neeraj, unmute.
Thank you. Sorry. I have a couple of questions to you, sir. One is regarding luspatercept in thalassemics. There is known to cause thrombosis. So I was just wondering, in MDS, especially in thrombocytosis, in say ring sideroblasts with thrombocytosis, is there any concerns regarding thrombosis for this drug? And
we haven't seen thrombotic. We haven't seen any thrombotic complications in those patients. In fact, in the Medalist trial, patients with high platelet counts have been those responding best to the treatment with luspatercept. So especially the RARS-T subgroup seems to be the one that responds best to luspatercept. And interestingly, thrombotic events are not very prevalent in this patient population.
So if I may ask my second question, it is regarding the high-risk MDS, and if it's a transplant eligible patient, how would your NGS results impact your decision making regarding the timing of the transplant?
It does actually probably impact on the addition of drugs after transplant, not so much on the timing of the transplant. I'm going to tell you why. We are switching a little bit in Germany to early transplant, because there are some data which are not randomized, but there are some data that appear to show that when you treat and retreat patients with myelodysplastic syndromes, you seem to select the worst mutations, and you have a very bad mutation prevalence at the time of transplant. So what we are trying to do is really And I would say sometimes independent of the blast count, what we are trying to do is go for early transplant in those patients with a blast count up to 20%. Really go for early transplant instead of trying to treat and retreat those patients for instance, with hypomethylating drugs. In a trial that we have done here, the Ven+Aza allo trial, called the Ven+Aza allo trial, what we have seen is that 38% of our patients started with azacitidine in this randomized trial actually did not make it to a transplant. So we lost 40% of the patients before transplant from progressive disease or from infectious complications or other complications. So as a matter of fact, I think it's important to say that we are switching to early transplant as early as possible, rather than trying to do NGS panel target some clone and then see reemergence of other clones and then going to transplant later, etc. Because the later we have done transplant, the worse were our results. So we're kind of pushing forward with the transplantation.
Thank you.
Thank you, Neeraj. Go to Dr. Pranta, please.
Yeah, thanks for that illuminating talk. I think you have already answered part of my question. It's more philosophical that when you have so many agents working in different pathways, what would you prefer to design a clinical trial in future? Would you like to bombard with a combination of those agents, or would you like to use them one by one using your biomarkers? So that is my question to you.
No, I think this is an excellent question, and I think what's going to happen is that we are going to bombard the patients with different agents. The problem with this is going to be to prevent long-term neutropenia, as a matter of fact. But I think if you can target CD47 and you can use BCL2 inhibition, I do really think that you might go into the right direction here, or sabatolimab in combination with magrolimab or something. This is going to be an answer, because if we use those drugs one after the other, my fear is that we are selecting the worst of the worst who are going to proliferate whatever we do afterwards. And therefore, I think hit hard and early is going to be the answer.
Thank you. Thank you, sir.
Thank you, Pranta. Dr. Sonali.
Thank you, sir. I would just like to ask about the low-risk MDS patients. Looking at the data of luspatercept, it's very promising. I just want to know that, do you have any other predictors of response other than the ring sideroblast? And you just answered, that a part of the question is high platelet count. So is there any, are there any predictors of response?
Not really. It actually is the SF3B1 mutation. It also is patients like SF3B1 positive patients with low platelet counts are not a very good patient population to be treated with luspatercept. It's really the classical, I would say, the classical RARS phenotype. The patients with higher platelet counts and lower transfusion burden. It's actually lower transfusion burden doing better than higher transfusion burden. The numbers become a little bit low when you look at the subcategories, but I think as a whole you can say that the lower transfusion burden patients do better than the higher transfusion burden. So my take would be lower transfusion burden patient with an EPO level not sky high, because the lower the EPO level, the better it is, the response is also, than the typical ring sideroblastic and the high platelet count. I think with these four parameters, you should be able to find a population that really predicts, is predictive of response.
Thank you, sir. Just another on the same note, like in low risk MDS patients, now that we expect that it's going to be available soon in the market, looking at the, promising data. So what would be the approach? Like if it's an, not eligible for transplant, that's easy. But if the patients are around 50 to 60 years, would you like to, give them sequential treatment like erythropoietin, then this luspatercept, and wait, like the transfusion burden keeps on increasing before we take a call on transplant, or would you like to get them into transplant early?
I have seen wonderful responses on patients with luspatercept, patients who have had 14, 16 red blood cell transfusions before and then, become transfusion independent. I would probably give it a chance to see a response with luspatercept. I have seen also patients who actually appear to have a different disease at the end of the day. They were ring sideroblastic myelodysplastic syndromes treated with luspatercept, becoming transfusion independent, and then at the end of the day, after 2 or 3 years, having myelofibrotic MDS. So what I think, what is important and interesting is to push those patients into non-transfusion dependence and then still evaluate them for allogeneic stem cell transplantation in case of worsening. Because what we know is that the response is not going to last forever. I mean, this is a fact. I mean, even if you take the cumulative transfusion independence rate of 80 weeks, it's going to be a year, 1.5 years, 2 years maximum, and then the patients are going to become transfusion dependent again, with very few responses, being more durable than 3 or 4 years. So I do think that the thought is still with allogeneic stem cell transplantation in the long run, but it gives you really the possibility to breathe for a while and to see how best to tackle iron overload, how best to identify the best available donor, etc., etc.
Thank you. Thank you.
Thank you, Dr. Sonali. Dr. Prashant.
Hello, sir. Am I audible?
Yes.
Yes.
Hello, sir. It was an excellent talk. I joined a little late, but the armamentarium, if you see, it's really interesting to see wonderful drugs that is coming out in the management of MDS. However, having said that, we are sitting in India, at least another 5 years or 6 years down the line, we can expect these drugs in the market. So till then, in a high-risk MDS patient who is not responding to azacitidine, as a monotherapy, what would you suggest? Because venetoclax is still expensive in our country. It is not easily available. So switch over to decitabine and C, or add on drugs like cytarabine to azacitidine and C. What would be your suggestion for transplant ineligible patients?
Yes. Well, you know that these patients do usually fare badly, and median survival of those patients after failing azacitidine is only 5 to 6 months, and we know that. So different approaches have been taken. One has been using decitabine, as you say, and one has been just switching to cytarabine, or for that matter, other drugs like melphalan or something. I think in countries, but also in Germany, actually, in some patients, who come in, are elderly, have a low blast count AML or a low blast count MDS, like 10, 12, 13% blast, and a normal karyotype. You can actually very well use melphalan, 2 milligrams, 1 tablet once daily, spare them azacitidine, spare them the injections, just give them a melphalan tablet for 60 days. Many of those patients, I mean 40 to 50% of those patients will have a wonderful response, will have a normalization of their treatment. I've just done it in a 90-year-old patient who has had a wonderful response, who is doing well and is transfusion independent. You don't spend any money, and melphalan tablets are kind of cheap stuff, and seeing responses. Now, if these patients have abnormal karyotypes, and I mean complex karyotypes, it doesn't work at all. Then azacitidine is probably the only option. Now, if they failed azacitidine in that case, I think best supportive care is still probably the best option, because fiddling around with other drugs like cytarabine, etc., is not going to help you. You need to see the reality. And I see these realities also in Germany. I mean, I say, listen, in your case, what can you do with an 88-year-old man that I'm seeing at the moment? I'm not going to add Aza to venetoclax, and the guy is going to become neutropenic. He comes from further away. He's having 60 kilometers to do a single way. It's not going to help. I mean, let's be honest. I mean, let's do best supportive care on those patients and see how they go.
Thank you, sir. It was, I think, a wonderful learning experience.
Thank you.
Thank you, Prashant. Dr. Anu?
Yeah, hope I am audible.
Yeah.
Yeah, so not infrequently, sometimes we come across 5q deletion as the only abnormality by FISH, but the patient doesn't fit into the classical phenotype. So for example, I can remember elderly gentleman who had pancytopenia, even the platelet count was low, and we picked up 5q minus in by FISH, and NGS is not commonly used in clinical practice due to our restraints. So in such a situation, what is the role of lenalidomide? Because I haven't had good response with lenalidomide in such patients. So would you try it, or would you go directly to hypomethylating agents, or is there any other option?
Yeah. Lenalidomide doesn't work in those cases very well. I agree with you. Our experience is the same. If you have a advanced patient with pancytopenia and del5q, lenalidomide usually is not the best option. Lenalidomide really is an option for the typical 5q patient. Probably those who have had erythropoietin experience before, and then you give them lenalidomide, and you have the nice response. But your patient case would rather be an hypomethylating agent patient.
Thank you very much.
Thank you, Dr. Meet.
Thank you, sir. Thank you, sir, for this wonderful interactive and academic thing. So, like, we have been exposed to treating our patients with venetoclax for the last couple of months, so most of the questions are being directed in that direction. So I have a similar question. Do you have any treatment differences in terms of exposure days for venetoclax for MDS versus AML? So, like, yes. Is it going to make any difference?
Yes. So in myelodysplastic syndromes, we tend to treat those patients with shorter exposure for venetoclax and with lower dosages. So 400 milligrams, 14 days would be our MDS target. AML targets would go 400 milligrams to even up to 800 milligrams, and we would actually add it 28 days until we see severe neutropenia, severe cytopenia in those patients. So I think there is a difference. I think you have a smaller pool of stem cells. You have a higher probability of stem cell ablation in myelodysplastic syndromes, and therefore you need to be a little bit more cautious in MDS than in acute myeloid leukemia.
Okay. And one more thing, this is for a high-risk MDS who undergoes a matched sibling donor transplant, would you be tempted to go in for a venetoclax maintenance in such patients, or it's too primitive to say something?
I think it's too premature, because we are not sure we are not going to suppress the normal hematopoiesis with it. I think there's not enough data to, at this moment, advocate, adding venetoclax post-transplantation.
Thank you, sir.
Thank you. Dr. Anil? Okay, till Dr. Anil comes back to us, we have a question from the audience. This is related to thrombopoietin analogs in the management of thrombocytopenia of MDS. Do you have a specific policy?
The one specific policy I have is that I don't use it in patients with a higher blast count, because what we have seen is that we tend to increase the blast count in patients that have already blast excess. And both drugs, L-Trombopac and Romiplostim, I'm not so sure about Avatrombopac, but L-Trombopac and Romiplostim do have the ability to increase the blast count in patients who already have a blast increase. Now, for patients with lower blast count, which means less than 5%, my take is that you can use both drugs. You can use both drugs safely. Depends a little bit on your patient profile, whether you want to give them the tablet or whether you want to give them an injection. I'm using high doses. So with Romiplostim, you would go to the 10 micrograms per kilogram body weight. With the L-Trombopac, it's 150 milligrams or even higher. Depends a little bit on the physiognomy of the patient also. If it's a very small patient, very low kilograms, you would use a little bit less. You would probably go to the 150. But apart from that, I sometimes go up to 300 milligrams of Revolade. And, I do not try and normalize the platelet count. This is another important aspect. I am happy with an platelet count that goes up over 25, 30,000 to reduce bleeding. But apart from that, I would then, tailor the treatment to a platelet count that is acceptable, so that I do not overstimulate also stem cells and maybe malignant stem cells.
Has Dr. Anil joined back? I think struggling with his connections.
Anil, sir, I'm here, sir.
Are you there? Okay, go ahead.
Yes, sir. Yes.
Go ahead, Anil.
Hello?
Yes, Anil, we can hear you. Go ahead.
Sir, I just wanted to ask about a low-risk MDS, sir. This patient had hemoglobin of around 6 and the TLC and platelet was normal. So initially we gave some therapeutic trial with iron and vitamin B12, but it was not improving. So when we did a marrow showed some erythroid dysplasia. Other than that, karyotyping was normal. Then his for MDS was also sent. It was not able to pick up anything. So we initially started with erythropoietin, 40,000 once a week, along with denozen. After 4 weeks, he was still not improving. After 4 weeks, and so I thought I will continue for another 4 weeks. So I gave a total of 8 weeks. Unfortunately, after 8 weeks also there was no response. So I started on decitabine, and after starting decitabine, patient started improving for about 1 year. Patient was doing well for 1 year, but unfortunately after 1 year, her hemoglobin started falling down again. Now my issue is at the baseline, she was a low-risk MDS, and she was 50 IDS. They are not very keen for transplant also. They are not, like when we discussed about this option also, they are not interested. So what can we do further in such a case? And will there be any role of transplant in the low-risk MDS?
So I understand you have a 58-year-old patient with a normal karyotype who responds to, although being only transfusion dependent and not a high-risk MDS with an increased blast, responds to hypomethylating agents and loses response to hypomethylating agents after 1 year. And, you know, the patient is not interested in undergoing transplant, fearing, you know, severe graft versus host disease and transplant-related mortality, etc. And now my second my second approach would now be to do a repeat bone marrow and to do a repeat cytogenetic analysis. Does the patient have the evolution of the disease, i.e. is the patient experiencing additional chromosomal abnormalities, some of which might be targetable, or is the patient still in a normal karyotype, and does the patient still have only less than 5% blast and transfusion dependence? Because in that case, you could go ahead and say, okay, we are going to you know, transfuse you for a while, give you iron chelation, and see how things happen and how you decide further on allogeneic stem cell transplantation. Now the patient is relatively young, so with an age of 59 now or 60, transplantation in this situation is going probably to be the best option, because you're not going to find a lot of other possibilities. But in some cases, actually, if you stop azacitidine for a while and keep the patient on transfusion, improve their iron status, etc., 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 you might actually want to reintroduce an hypomethylating agent, maybe azacitidine or decitabine, if the patient still refuses transplantation. And then you might actually see a second response, which is going to be shorter lived than the first response, but still, I mean, it's a viable option. And then, I mean, you need to tell the patient that at some point, I mean, your wisdom is gonna, you know, all you have is a couple of drugs, and this is going to end at some point. And at that point, this patient finally should actually decide whether or not they undergo transplantation, yes or no.
Thank you, sir.
Thank you, Anil. Another question from the audience. Like TPO analog, are you also concerned about giving GCSF to MDS patients having more than 5% blasts?
Yes, as a matter of fact, if the blast count is elevated, adding GCSF does have the a certain risk of increasing the blast count. On the other hand, I must say that if we look at AML studies, we know that the priming concept and also the concept of intensive chemotherapy with GCSF addition has not shown such a big difference in response rates, etc. So it's also not a primer for malignant blasts and increase in malignant blasts. So if necessary, and you are in ultimate emergency, obviously you can treat with GCSF, hoping that you improve the responses. But as a general rule, I would refrain from using GCSF in patients with higher blast count.
The question is from Dr. Ramesh about hypoplastic MDS. Do you treat them like aplastic anemia or differently?
I tend to use ATG-CSA plus minus L-Trombopac in hypoplastic MDS because it's actually quite difficult to sometimes differentiate between real hypoplastic MDS and aplastic anemia. We do have some patients with aplastic anemia who show cytogenetic abnormalities. We do have some who show dysplasia in the bone marrow also. So sometimes it's a little bit difficult. And previous studies with immunosuppressants in hypoplastic MDS have shown encouraging results. So I would go for that.
A related question is, do you believe in the entity of immune-mediated MDS?
I do think that immune-mediated MDS exists. Ghulam Mufti from King's College has often lectured about it. I have seen personally patients who certainly have had major immune complications with their myelodysplastic syndromes, and the pathophysiology that I presented with the inflammasome and the inflammatory impact on the bone marrow microenvironment, the expansion of myeloid-derived suppressor cells, etc., supports the idea of immune-mediated myelodysplastic syndrome. And therefore, yes, I would think this is certainly an important part of the myelodysplastic universe.
Thank you. Another audience question is from Dr. Abdullah about iron chelation. Do you always treat your transfusion-dependent patients with regular iron chelation and keep the goal of ferritin below 1000?
Not always. It really depends on the individual patient. Patients who are elderly and have renal insufficiency, patients who have diarrhea on deferasirox, etc., and patients who have a short projected median overall survival because they are very old, I tend not to bother them too much with iron chelation. Also, in some patients, I actually reduce the iron chelation below what is being referred as the optimal treatment with iron chelators. I actually give them a little bit, because what has been shown is actually that you can reduce the reactive oxygen species if you use lower iron chelation, and that you don't necessarily have to reduce the ferritin level as much also. So the labile iron in the body can actually be reduced even if you don't go for the maximum dose of iron chelators. So it really is an individual approach that you need to consider.
Right, sir. Another question is from Dr. Babita. TP53 mutated patients, do they respond to hypomethylating agents at all? Is it worth trying? Oh, absolutely. Patients with TP53 mutation respond actually relatively favorably to both azacitidine and decitabine, and we should go for this. The problem has emerged with what TP53 mutation actually means, because we do have TP53 mutated patients who have a monoallelic TP53 mutation, which is completely different from the biallelic or multi-hit TP53, which are doing worse than the monoallelic TP53s. So, I am a little bit wary of saying that some patient has a TP53 mutation and therefore we are, reluctant in treating them at all. No, to the contrary, I'm actually going for treatment of those patients with hypomethylating agents first, and then, in a second phase, then see whether I can go for an allogeneic stem cell transplantation. Right. Another question is about TAT2 mutation, whether these patients really do better with HMA.
I'm not so sure. I'm not so sure. It has been suggested that HMAs do, or patients with TAT2 mutation do better on HMAs, but, it's somewhat, I would say the jury is still out on that. The problem also comes from the fact that TAT2 mutation often is accompanied by other mutations, and therefore you don't know the individual impact of any mutation. But I think the jury is still out on TAT2 being a positive predictor of response to HMAs.
Another question is about RARS with thrombocytosis. If JAK2 is positive, will you give ruxolitinib?
Excuse me, what would I give?
RARS with thrombocytosis, JAK2 positive, will you give ruxolitinib? Zakavi.
Ruxolitinib is a treatment that is especially beneficial in patients who have certain problems like splenomegaly, who have continuous itching or other symptoms that actually lead to a reduction in quality of life. It is not so much a treatment to improve cell counts. And because of RARST patients having thrombocytosis, but this thrombocytosis leading rarely to complications like thrombosis, I don't see the point in treating a patient who may have a JAK2 mutation primarily with ruxolitinib. Now, if this patient has splenomegaly, if this patient tells me that they have other constitutional symptoms, then yes, I would go for ruxolitinib. But as a primary treatment, I would probably not go for ruxolitinib, but rather look at other treatment options.
The other question is about the type of ESAs. Is DARBE superior to EPO?
It's not superior, but it's probably equivalent. Now, the phase 3 study with darbepoetin was not a success. EPO alpha did better in a phase 3 compared to placebo than DARBE compared to placebo. But I think these were issues of patient inclusion, etc. I do definitely think that you can use them interchangeably, and it doesn't matter whether you use EPO or darbepoetin.
Dr. Thanuja wants to know, if EPO 40 does not work, you go to EPO 60. That does not work, you go to addition of GCSF. You follow this policy?
I always do that.
And then she has another part of the question. If with GCSF the WBC count jumps up, then do you decrease the frequency or doses?
I actually use a relatively low dose of GCSF. I tend to use the children's dose of GCSF once a week. I do not tend to use GCSF 30 or 48, which is the adult dose. So yes, I decrease the dose.
Another question is comparing azacitidine with decitabine. Do you believe there is a difference?
That's a short answer, no.
No. Right. I finished with the audience question. If you all have any questions, the faculty here.
I have a question, if I can just...
Go ahead.
So how do you treat a transfusion-dependent ICUS, idiopathic cytopenia of undetermined significance? So workup complete, nothing is there, but the patient is transfusion-dependent.
Yeah. So I think ICUS, ICUS is a very difficult thing, because if you say ICUS and you mean true ICUS, then you have idiopathic cytopenia, but you don't have clonality. And if you don't have clonality, then it's so difficult to know whether, this is actually myelodysplasia in some way, or if if it's functional, I would say functional myelodysplasia, or if the patient just really has another problem. And it comes to really investigating this anemia a lot. I have this one patient who has actually myelodysplastic syndrome, as it turned out, but on the same at the same time had angiodysplasia in the bowels and also has underlying autoimmune disease, which all added up to his transfusion dependence being somewhat very weird, sometimes needed a lot of blood, sometimes needed less, etc., etc., etc. If you have real ICUS and you can't find anything else and the patient is transfusion dependent, then in my opinion, they do have something that resembles myelodysplastic syndrome. They have ineffective erythropoiesis. And if you have ineffective erythropoiesis, then you need to target the ineffective erythropoiesis. And that might actually be targeting the early maturation of erythroprogenitors with EPO, if that's possible, and then later stages with some other drugs, which may at the end of the day be oral azacitidine or TGF-beta inhibitors.
Thank you, sir.
Another question has come up from audience. Darbe 500 once in 2 weeks. Some response. Can I go further up on the dose or frequency?
Absolutely. I would probably go for Darbe 500 every week, see how that goes, and then add a little bit of GCSF and, you know, then tailor off the dosage.
Another question has come up. She has a patient on azacitidine. The blood counts have absolutely normalized. Can she reduce the dose or frequency of azacitidine?
Never do this. Never do this. I have done this with very bad experience, and I'm really scared of reducing the dose. I have had patients pleading with me that they wanted only 3 doses a year or 4 doses a year because they wanted to travel, they wanted to see their children, they wanted blah, 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 blah. And I did it, you know, they pleaded and pleaded with me. And at the end of the day, this disease came back. You can't actually get them back on track. Even by changing then the HMA or something, these patients then lose their response. And if they lose their response for some reason, and I don't know the pathophysiological basis for it, you can't get them back on track. And therefore, I would not do it. I mean, if the patient experiences cytopenias or something, then you can reduce the dose. But I would actually refrain from prolonging the interval between 2 AZA or decitabine cycles by more than 7 weeks. 7 weeks is the absolute ultimate limit that I accept, and I would not go for to extend it.
Another question has come up is about higher risk MDS patient transplant fit. Can he be transplanted straight away without bothering about the blast reduction?
Absolutely. Higher risk myelodysplastic syndromes, transplant eligible with, say, 18% blasts, go for immediate transplant. This is possible. Not everybody does it, though. Not in Germany, not in the other EU countries. Many want to debulk the patients, but I can tell from the Düsseldorf experience that really immediate transplant is at least as good as you know, transplantation after debulking. So I do think that you can do it if you have the available donor.
Thank you. Dr. Tanuja has another question. Her patient has done very well on lenalidomide, 5Q minus. Hemoglobin is excellent. Can she reduce the dose or the number of days she is giving lenalidomide?
Absolutely. So with lenalidomide, what you can do is you can look at the response, and I encourage you to do a cytogenetic. And if you do a cytogenetic analysis and see that 5Q has vanished, what I do is I treat them for another 6 months and then stop lenalidomide altogether. I've seen patients doing so well on it. They have remained transfusion independent for a decade. And interestingly, I have this one patient who actually had reappearance of del(5q) after 3 or 4 years and wasn't transfusion dependent. So we followed her further and further and further. And during the next 5 to 6 years, her del(5q) would expand to a level that she has become transfusion dependent again. So I actually think that you can interrupt lenalidomide in del(5q) patients once they have gone into complete cytogenetic remission, and you can actually stop it altogether.
Thank you. And then another question has come up is, are other IMiDs effective in 5q minus? Other IMiDs, thalidomide, pomalidomide.
I see. So thalidomide definitely is effective in del(5q). We have data on a couple of patients who went into complete remission with thalidomide. The problem is that at the dosages that you need, you get a terrible polyneuropathy. And if you increase the hemoglobin to 12 grams and the patient can't move, there's no point. So yes, they do. Pomalidomide, I'm not so sure because I've never used it. From previous studies, I think it does work, but I've never used it myself. So yes, you can use other IMiDs, but Revlimid is probably the optimum in the treatment armamentarium.
The next question is, your patient who got 5q minus again after discontinuing len, did he or she respond to len again?
So it took a long time for her to, several years for her to reappear del(5q. And yes, they do respond again. You can actually use lenalidomide again. Now, the other question comes up. If you have a patient who is non-transfusion dependent with del(5q, if you start them on lenalidomide, do they benefit? And there was a talk at ASH from the Spanish group who showed very nicely that actually they did prolong the median time to transfusion by 6.3 years by using 5 milligrams of lenalidomide in patients who were non-transfusion dependent del(5q). So, there are several approaches to the drug, but to the disease. But yes, in case of patients who have stopped lenalidomide and need another row of lenalidomide, yes, it does help.
Dr. Lee Binson wants to know, 4 cycles of HMA, no response. Can she stop further treatment? 4 cycles.
I think it's a bit early. I'm going to tell you the story of a patient of a colleague of mine who was treated with azacitidine, and after 4 courses did not have a response. But he was eager on treatment and continued. And I didn't follow the patient. So one day I come into the office and I see next to the office of my colleague this patient. It was 1.5 years later. I say, what are you doing there? He says, yeah, I'm waiting for my treatment. I say, so how many cycles have you got? He said, 19. And I said, do you have a response? He said, no response. And, I said, I was nice. I said, okay, have a great day, etc. And the patient responded after 21 cycles. And he's still on the drug at 176 cycles now. I have followed the guy. At 176 cycles, the guy is still getting azacitidine. I can't believe it. This man is a world record holder, I suppose, of azacitidine. So, after 4 cycles, it's definitely too early.
So that's again last question from the audience. Faculty here, anything left?
Sir, I wanted to discuss a specific case, if I can share my screen. Can I do that?
You can share your screen. Yes, you can.
Just to show the clinical details, just 2-3 slides.
Go ahead.
Hope my slide is visible.
Yes.
Yeah, so just about one patient. It is probably related to the immune-mediated MDS that we briefly discussed. He has had a good response.
Put it on a slideshow mode so we can see full screen.
Sure. So I think it is probably related to the immune-mediated pathophysiology of MDS that we briefly discussed. And it is a very unusual case. That's why I put up the details. So this is a 64-year-old gentleman, absolutely no premorbidities. And he had presented to various specialists with reddish, widespread, itchy, intense itching, skin rashes. It was getting worse. And no response to treatment so far. No past history of allergic or skin disorders. No history of psoriasis in the family. No recent new drug intake, and no organomegaly. But he had mild pancytopenia. That's how he got referred to me also. So this was his skin rash. It was mostly in the upper and lower extremities. Trunk was spared, no lesions on the face. It was erythematous. You could actually feel the lesions. It is slightly raised with irregular borders. So this is just a magnified picture of that. He had intense pruritus and no response to topical antifungal or steroid creams. So because of his pancytopenia, hematologists got involved. So when we looked at this peripheral smear, there were dysplastic neutrophils with less granulation and vacillation. Bone marrow was normocellular, and there were striking dysplastic features in all the three lineages, and abnormal location of immature precursors in the trifine. And by FISH, we did pick up 20q deletion. So he had a skin biopsy, and this is what we saw. It was a perivascular mixed inflammatory infiltrate with marked extravasation of red blood cells. His ANA profile was negative for all the antibodies. C ANCA, P ANCA negative for vasculitis workup. And this was our pathologist's final diagnosis: leukocytoclastic vasculitis secondary to MDS MLD with 20q deletion. So we treated him with decitabine, standard dose 20 milligram per meter square, 5 days a month. And he started showing response by the second cycle itself. And by the end of 6th cycle, this is the appearance. So this is actually quite normal leg. Only the residual hyperpigmentation is left. No pruritus at all. And the counts were totally normal. He was never transfusion dependent, by the way, even when we started. And bone marrow was repeated. And there were still some subtle dysplastic features which we could see because we knew that he's an MDS patient. Otherwise, we would have missed it, I suppose. And FISH showed that he had lost the 20q deletion. So these are the questions. One is, how commonly does MDS present with skin lesions? Not just concurrent symptom, but presentation with skin lesions. And how do you explain these cutaneous manifestations? Is it immune complex mediated? And finally, many of our patients are reluctant to continue HMAs. I'm glad to hear that your patients are also pleading with you. So it's not unique to our country. So since he has had disappearance of his bothersome symptom of pruritus, he wants to discontinue. So is there any data for fixed number of cycles, reduced number of days per cycle, or less frequent cycles, which I think you have answered, maximum 7 weeks, or any oral HMAs which we can switch? And finally, if this patient had troublesome recurrence of his disease, how likely is he to respond to HMAs in case of further disease activity?
Thank you for this very interesting case. What I have understood is that you do not have a blast increase in the patient to begin with. So the patient actually did have the leukocytoclastic vasculitis, but he did not have blast increase in the bone marrow. And treatment with decitabine resulted in improvement of everything, really. His peripheral blood counts also improved. Now, because this patient does not have a blast increase, does not have an abnormality in their bone marrow cytogenetics, does not have very adverse genetic abnormalities, I suppose that reduction of cycle, prolongation of cycle length is probably easier to be supported. And also I could imagine that dose reduction could be done in this patient, because what you probably need is a maintenance dose to reduce the ability of this clone, whatever it is, to actually extravasate and do this leukocytoclastic vasculitis. So in this case, I would be less strict than in the cases where the patient started with a clear increase in blast cell counts on hypomethylating agents. The other thing is the presentation of myelodysplastic syndrome with skin changes is rare indeed. It's actually, about 15 to 25% of patients with myelodysplastic syndromes may have additional autoimmune problems, but the presentation as a skin abnormality is very rare. And I myself have seen only very few cases where the patients have actually all responded to some kind of more intensive treatment, be it azacitidine, as in your case, or decitabine, as in your case, or in patients who have presented with skin changes and had increase in blast counts where we did intensive chemotherapy. So yes, I think you probably can reduce now. Yes, I think you can prolong the cycle length. Yes, I can even imagine to interrupt treatment altogether to see whether the patient benefits from at least a drug holiday for a couple of months.
Thank you. Thank you very much.
Thank you, Dr. So another question has come up from the same lady friend, that if not 4 cycles, then how many cycles will be enough to call it a day if there is no response?
Yeah, so the number of cycles after which the response rate is very low is about 9. So I think if you give 9 cycles and there's no response, you either believe in the patient that I have that I've alluded to, and who responded after 21, or you you just stick with the science and say after 9 cycles the probability of response is so low that it is okay to interrupt.
Dr. Krishna Ratnam has asked a question. In all your patients of ring sideroblast, do you look for copper deficiency?
I usually look for copper deficiency at the beginning. Honestly speaking, I've never found any copper deficiency in any patient, but I'd still do it because of the reports that are around. I mean, I think it's taken on the blood sample that you take initially. So yeah, I think asking for a copper is probably not bad.
Thank you. Again, no more questions from audience. Anybody over here? So I think we have come to an end. So before we just thank you, I must say that there is another record in the Guinness Book that a teacher goes all the way to mother's place to fulfill the commitment he has made to the Indians of taking the lecture early morning. Thank you so much.
Yes, thank you.
Thank you so much for doing that. I didn't realize the difficulties you have gone through to fulfill your commitment to us. Mother must be very happy and delighted that you came to her place, at least because of this. Thank you so much for taking this talk and discussing so many aspects of difficulties of our colleagues from this country and from the audience.
It's been a great pleasure. It's been a great pleasure. And, as you know, I'm very fond of your place, and it's been a fantastic time in Mumbai. And I can't wait to come back to this absolutely astonishing country.
Thank you, sir. It's not going to be very far. I think early next year, there will be no COVID in the world. Thank you.
I hope so. At least I have received both of my vaccinations already, and I hope that the data is correct, that I cannot contract it, but I cannot also give it to anybody else.
Great. Thank you so much, sir. And thanks to everybody for making this so lively and interactive. And have a wonderful day ahead. Thank you.
Thank you very much. Bye-bye.
Thank you, sir. Bye-bye.
Thank you. Bye-bye, sir.